So thank you for inviting me here to speak. I suppose first and foremost, I must say that I'm a trustee of the Lindsay Leg Club Foundation, so very proud to be part of the family, as everyone was saying yesterday. And I think it's very much the concept of the Leg Club. I'm also a lecturer at King's College in London, and there I lead the tissue viability modules, both level 6 and level 7, which seems to be going a bit global at the minute. We're doing quite well. And I also lead the pre-registration person-centered care modules. So for my sins, I lead a module for probably over 260 pre-reg adult nurses who are coming into the profession of nursing. And we lead very much from the McCormick and McCants. Some of you may be familiar with Brendan McCormick and Tanya McCants, who wrote all the books on person-centered care. So it's very much a philosophy that we believe at King's. Aside from that, as if I didn't have enough to do, I have two clinical roles. My first clinical role is I am a nurse consultant with the charity Change, Grow, Live. And that charity is a charity for drug and alcohol services here in the UK. So I work as a nurse consultant there, looking after people with a history of injecting in the lower limb and people with the history of homelessness. And then my other clinical job is that I work alongside Mr. Biazzi, who you've heard from already, and we run a private vascular and wound care clinic in Tunbridge Wells in Kent. And we've been running the clinic now for about 2 years, and we've had some amazing results. So I'll be talking to you a little bit about our clinic and the patients that we see, but also the patients that I care for in the homeless and inclusion health sector. So I suppose touching on some of the concepts or themes that have been running through today's sessions, I want us to explore together and talk together and discuss openly. And there's some questions that I will come back to that people have raised already about some of the complexities in caring for all people living with leg ulcers. So not just older adults, as we may mostly see with venous leg ulceration, but people across the spectrum of leg ulcers, people living in the margins of our society, such as people experiencing homelessness and people with a history of injecting drug use. And to be familiar with the terms and language, we no longer use the term IVDU because of labels and stigma that's associated with that. So we talk about people who experience homelessness, people with a history of addiction or injecting. And although it's quite long-winded, that's who they are and that's their history, but they're not defined by it. So we need to be careful when somebody comes in and they may have a history of injecting. They're not labelled an IVDU, because once that's on your notes, it's on your notes for life, like everything else we may go through. So we need to be really careful about the language that's used when we talk about people from all walks of life. I want us to challenge ourselves and our teams. Look at our caseloads and identify people that are not healing. It's my opinion and my experience, and I've been in wound care studying and researching since 2005, that people with leg ulceration that with a treatable etiology should be healing. It's absolutely unacceptable, borderline negligent, cruel even, for people to be living with treatable venous leg ulcerations. It shouldn't be happening. And although people say, whose responsibility is it? And I think this question came about yesterday. So who is responsible? Is there one person that is? I don't think so. But in my experience, a patient seeing the right clinician at the right time with the right compression, which we'll talk a bit about later, they should be healing. And in my experience, they do. What can be done and why? So what are we doing? And that means looking at how we practice as clinicians and how our team practices. And I think sometimes as nurses, we are very personal in how we take feedback and how we give feedback. This is not a personal feedback on an individual. This is a professional situation. Are we providing competent therapeutic care for that individual or not? Do we need to upskill ourselves? Probably yes. So if a patient is not healing, there's a reason why. And certainly with the homeless population, 9 times out of 10, it's because of the people they're seeing. It's not always because of them not coming to clinic. Because if they're not coming to clinic to see you, there's a reason why. And 9 times out of 10, it's because of that experience. I want us to reflect on your current training needs. Now, having done research and masters in tissue viability, I find myself still back at King's in a student seat this year doing my independent nurse prescribing course. So it's never ending. So my question to you is, what are your training needs? Is your manager supportive? Are your teams supportive? And if they're not, maybe it's time to take a change, make a move. Because if you're not getting the support you need for your training to be able to practice competently, you need to move on. And I've seen that a lot in tissue viability. So don't be afraid of change, and certainly don't be afraid of coming back to university. I'm lecturing at uni and I'm sitting in a student chair, and it's doable. It's something that we have to embrace throughout our lives. And then I suppose everyone has talked about multidisciplinary team and locating your contacts in practice. Mr. Biazzi took my line, but actually we've all spoke about it. And I've always been quite forceful with this in the sense of going out into a hospital, ringing somebody. But usually I like to meet people face to face. So a consultant dermatologist, a vascular consultant, because they don't know who we are. They don't trust us. And it's all about building those personal relationships so that when you ring that consultant or you ring that nurse podiatrist or secretary, GP secretaries, now they're be a handy group of people to know and to personally know, then they trust you. They will take that information. So we really need to be forceful in that. So all the pictures you see today are people that I've cared for, people that I've healed, people that are still here with us today, and the majority, unfortunately, are not. So my question to you is, from this first slide, what do these people and legs have in common, do you think? So I suppose one of the first things that they have in common is that they've all experienced homelessness, different forms of homelessness. The gentleman on the top right with the rollie, he was in a hostel. He's quite an elderly gentleman. The gentleman below him was begging at King's Cross, sleeping in the station. And I used to have to dodge him routinely to get the train. The lady in the middle is a French lady. She was working in a very high-end store in London as a florist. And she was squatting in Hampstead in a very posh flat. And the gentleman to the left, he was living with his mum. And then the gentleman just in the middle was sofa surfing. So out of all these people here, only one was considered street homeless. Everybody else had different forms of homelessness. So, you know, we are living in a time where we see it all on our streets, in our cities, in the urban areas, but it comes in many, many forms. And I'm sure some of you, if not all of us, have been touched by it in some way, whether looking at it in the streets or not. What else do these people have in common, do you think? They all have a history of injecting in the lower limb. Now, interestingly, the only person who was still injecting is the gentleman that both the legs are showing down on the bottom right. Everyone else had stopped injecting 20 years ago. Now, that's quite scary, isn't it? To think that you could have injected in the 70s or the 80s when people did. And then the venous disease progressively got worse over time. And that's quite shocking to a lot of these people. It's quite traumatizing to think that that was in my previous life. I left my drug use a long time ago, but yet then you get a venous ulcer. Anything else? We talked a little bit about mortality. And I'll show you some statistics on that in a minute. But everyone apart from two people here have passed away. And I was directly involved with two of the gentlemen's passing. The Irish guy on the far right had untreated hepatitis, which we now know is you can have a vaccination for it. But he was so terrified of the treatment of interferon, which was so aggressive, that he had cirrhosis of the liver and unfortunately passed away. The gentleman in the middle died of lung cancer in ICU, and I was with him and his daughter when that happened. And the other gentleman up the top right, unfortunately, had an ischemia, lost his leg, and as Mr. Biazzi talked about earlier, passed away from that. So this is real life, you know. This is the real kind of what I call the edge of leg ulcer management. And the other thing that they have in common, which is probably the most lovely thing to say, is that they all healed. Apart from the guy in the top right who has an arterial ulcer, again giving it away with the cigarette, and they all healed. Why? Because they engaged, they came to their appointments, and they had compression. So, excuse me, we talked a little bit about homelessness not simply being a matter of lack of housing. It's deeply, deeply rooted in deprivation, social inequality, and exclusion. And we need to be extremely aware of what's happening in our local communities, maybe our neighbours down the road. It's everybody's responsibility. It's a political responsibility, as Anne Clewett would say if she was here today. And I think certainly for those working in the community, and even those of us in the hospital setting, we have a responsibility to be able to read up on the literature around this. So I'm not sure if you're familiar with this guy, Professor Sir Michael Marmouth. He is a professor of epidemiology at UCL in London. He's an amazing man. I don't know him personally, but I have listened to all his podcasts and webinars. He's also the director of Institute of Health Equity. And he published a report probably in the early 2020s around social inequality, health deprivation. Of no surprise to you all that certain parts of England, with not having education, employment, people grow up poor in worse health conditions and die younger. Now, Prof. Marmot went on to do this review again in 2020. And I'm afraid to say the results are not any better. So people can expect to spend more of their lives in poor health and poverty. Improvements to life expectancy have stalled and declined for the poorest, 10% of this being women, mainly single mothers. The health gap has grown between wealthy and deprived areas. Well, those of us living in the real world, we're seeing that. And I think, you know, in certain parts of Europe, I don't see it as much when you go to France or Italy, but here, and certainly in Ireland as well, it's so visible. It's quite shocking. And it's normalised. We've normalised it. And place matters. So living in a deprived area of the northeast is worse for your health than living in a similarly deprived area in London. So much so that your life expectancy is less than 5 years. So, you know, it's something to take note of. And please do link in with, I think there's a newsletter even for the Department of Health Equity if you want to get involved and get newsletters on it. Coming back to the mortality of people experiencing homelessness. So in Camden, for example, now these statistics are back from 2019, but they haven't changed. So in Camden in London, the average age mortality for a man and a woman is like early 40s. So that's probably a lot of us here. So it's absolutely shocking. And we need to be aware that for the people that we are caring for, that is very much their prognosis. So going back to one of the gentlemen we spoke about earlier, this was a guy who was from Dublin. He was a heavy drug user. He was a heavy dealer. He was in and out of prison for a long time before he came off drugs. And you can see from the injecting marks, he injected all over his body. He had skin popping, abdomen, buttock, everywhere. When I originally saw him, the ulcers were very much from that first picture, and we instigated compression therapy straight away. There's no hanging around. You know, you check the pulses. If you're lucky, you do the Doppler, you get them in the compression. There's no come back tomorrow, I'll check with my manager and make a few phone calls. They won't come back. So it's all about that first experience. Looking them in the eye, shaking their hand, even if it's not the cleanest, you know, that's what you have to do. Because they're watching you, judging you, sniffing you out, sussing you out to see, are you judging them? And the dynamic is really interesting. So if you go in there and you hadn't had any sleep, or, I don't know, you're in a bad mood, they'll be thinking it's them. So you need to be really, really kind of aware of your persona, because they're very intuitive, because they're survivors. These people live lives we can't even imagine. But going back to this gentleman, starting with the compression, cleaning is really important for these wounds. I'm not talking about water here. Now, I know the evidence says you can wash leg ulcers in warm tap water. It doesn't work for these people. They're not living a lifestyle in a clean environment. They need some form of cleansing solution. They need aggressive cleaning of the skin and of the whole legs. And for this particular guy, I bandaged him right up to the groin with the short stretch system. Again, no hanging around. Get him in, get them in the compression. And he was healed within a matter of months before he passed away, which meant he could go to Lourdes with his mother on a pilgrimage he'd wanted to do for many years. And he'd been off drugs for years. He'd done his time, as he said to me. So just to reflect a little bit about the CAP classification, we've talked about it a lot today. I think as nurses, and I'm sure many of you will agree, we need to do a lot more about that. We need to be educating ourselves. Interestingly, and this is important to say to people, if you come into contact with someone with a history of injecting, ask them, have you ever used drugs? What's your alcohol consumption? We're kind of a bit reluctant to ask those questions. Like, we don't talk about intimacy in healthcare, which is another big taboo, and I really enjoyed that the ladies brought that up. So we need to ask them, how long ago did you inject? What did you inject? It's quite a traumatic conversation, but make sure you have that so that you document it and that your colleague doesn't need to ask it again the next time, because that regurgitation is really difficult for this group of people. It's traumatizing. What I will say is that you can be predisposed to these wounds, as we know, without ever injecting. So somebody could come in with a strong family history. They may have had multiple pregnancies, DVTs, orthopedic surgery. We know the risk factors, and then they injected. But when you explain that to somebody with a history of drug use, it's like, they can't get over it because they blame everything on it. And although no doubt there is a link, we need to be aware of the other risk factors. I've brought this gentleman up because, well, for many reasons. He made me smile, he made me laugh, introduced me to Pink Floyd, which was, life-changing to say the least. But we need to have more research and evidence with working with people across the skin tone spectrum. And we don't have that. You can see from the photographs that I show you, most of them are white skin. We need to have more photographic representation of the spectrum of skin tones. And I'd like to say we're doing some research at King's around this topic, and how skin tones represent in dark skin tones. If you're interested, then please link in with me after. If you're caring for people with venous disease or PAD and you want to be involved in this particular topic, let me know. This is the lady, the French lady, who was a florist, who herself and her partner had used for many, many years together and came off heroin on their own, which is almost impossible. It is impossible. The interesting thing here was that her partner and her had been together since they were 16. He'd never seen her leg ulcer. How that happened. Obviously, they had an intimate relationship, but there was no... she never showed the wound to him. So it was very much about shame and embarrassment. And again, strong compression straight away, Doppler if you can. If you can't, pedal pulses. It's about that thorough clinical assessment. And I suppose I'm fortunate. I have colleagues over the years working in London. I can pick up the phone and say, what would you do? I don't work in isolation. I think it's just the worst thing that we can do. To be successful quick, you need to pick up the phone. And I think sometimes as nurses, we pull back from that for whatever reason. And I'll show you the last case where is a great example of MDT working. Of course, we can't talk about injecting in the lower limb without talking about arterial emergencies, vascular injuries. So the femoral vein in the groin is the main point of access. It's the best route. Injecting anywhere else, the veins go very quickly. You can inject into the femoral vein 15, 20 times a day quite easily. Even the most experienced injectors, as they might think they are, tapping into the femoral vein and tapping off the femoral artery. You can't see it, so you're going by feel all the time. The needle is tapping off the artery. It's causing a bulge in the artery, which leads to a pseudoaneurysm. This is a vascular emergency. It's a surgeon's worst nightmare. This particular person has had a bypass graft anyway. You can see the two scars. What they also have now is an infected pseudoaneurysm. It's a life and limb risk. And this person was still injecting. So this is a big operation. If they're lucky, they'll keep their leg, their life. So injecting below the belt or the groin is an absolute disaster. Anyone you come into contact with, need to be checking their groins and checking anywhere else they're injecting. Other things to be aware of is hygiene, what they mix the drugs with, and also some of the spoons, etc., that they heat the substances with. So be very aware of this. How am I doing for time? Okay for time? Thank you. And now moving to our old gent, bless him, who we met in the hostel. This is another vascular emergency. This is an ischemic leg. And he presented with all these signs and symptoms. So he had, previous to it becoming as this, he had claudication, cold extremities, he had no pedal pulses. Unfortunately, the leg was not salvageable and he was hiding it under his sock. So, for some reason, when we do physical assessments of patients, we don't check both feet, both legs. And sometimes they don't want you to, because the socks and shoes may have been on for weeks in my experience. But we really do need to check all the time, across the board, both feet, both legs, and both hands, etc. It's not enough just to look at one. If you come across somebody like this, you send them to A&E. If they're not going to go, you go with them if you can, which I'm sure many of you would, or you call an ambulance. You cannot wait around for this. We've talked lots about recurrent cellulitis and dependent edema over the last day or so, and just to relate it to the homeless population. So for the majority of them that are street homeless, they walk for hours every day. Hours. Particularly at night when it's very dangerous to be street homeless. Even for a man, you're walking around 3-4 hours a day. If you're lucky, you might find a bus and sleep with your legs down. So the chronic venous hypertension is a real issue here. And as we know, readmitted with cellulitis, some of these patients also have lots of varicose eczema, as was the case with this gentleman. I think Becky raised it earlier today. Can we really say that he actually had cellulitis? When I saw him, he'd one episode of cellulitis and then varicose eczema. In terms of treatment, strong compression, skin care, and stockings, of course. Other complications that you will come into contact with, and again, this is not exclusive to the homeless population, is toes, nails, foot care, and shoes. And this is a guy living in a hostel. He was 90, used to be a boxer in London, entrenched in the whole lifestyle. You were never going to move him. He was just there to stay. It took months to even get him in. He had a nasty venous ulcer. But eventually, be persistent, be patient, be compassionate, be kind. They're waiting for you to say, you never turned up, that's it, you're gone, phone down. People have done that their whole lives to them. So they're waiting for that. So it's your job to just be, go the extra mile. And he healed as well. So foot problems, we see lots of trench foot, frostbite. It's quite common, lots of fungal infections, verrucas, etc. Because of footwear, sometimes people don't have shoes. They may not have a clean pair of socks. And this is the reality. So if you're going out in the community, buy a couple of pairs in the supermarket, in the secondhand shops. They're quite handy to have. And if you want to learn a little bit more about the people behind the lives that we're talking about, the lifestyles, some of you may have heard this lady before. This is Lorna. Lorna is a retired teacher. She's a mother. She's a grandmother. She's a wife. And her and her husband, Graham, had used for many, many years back in the 60s. And she openly speaks about it. In fact, her story is on YouTube, on the Society of Tissue Viability website. She talks about her struggles. She talks about being at the mercy of her GP. She talks about the stigma, the shame. And she has 3 beautiful children and grandchildren. So if you want to learn a little bit more about the people around this particular area, then I urge you to listen to Lorna's story. And of course, I couldn't talk about any of this without remembering this wonderful lady, Anne Clwyd, who was very passionate about this. She couldn't believe, like she had a leg ulcer herself, she couldn't imagine what it was like to be homeless in London with a leg ulcer. It just made her, she was distraught. And when she came to Parliament that day that she was discharged, as Mr. Biazzi said, literally, she walked from St. Thomas's to the Parliament with her cannula just out. She talked about this. And Anne kindly did some seminars and webinars with Legs Matter as well. So thank you, Anne. Moving on now just quickly to a case I saw with Mr. Biazzi recently. This is a Max Fax consultant who, with his lovely wife, a retired nurse, went to Florida. And in Florida, he thinks what he had was an insect bite, which I'm sure we see all the time. And on the way back, he developed a rip-roaring cellulitis, ended up in hospital for days on end. And it was his local hospital, which he knew, and he's happy for me to share the story. He speaks about it on our YouTube channel. He said they just left me with Inco pads. They never dressed the leg. They never looked at the leg. They just gave me antibiotics. There was no duplex done. So when we saw him in clinic, I think it was 7:30 in the evening, Mr. Biazzi wanted to blue light him in to hospital because he was really concerned. I mean, to another eye, you would question, is this necrotizing fasciitis? You know, to an untrained vascular eye, you think, what is going on here? But we said no. Multidisciplinary wise, we said no. He's on antibiotic therapy. Let's just wait. Let's start the compression. Let's just wait and see. And that's what we did. Dressings we use very plain, any ultra, which is a great dressing. Use it all the time, particularly for vascular patients when you want to keep it dry, but nothing to stick. So this is 1 week in compression. 2 weeks in compression. Again, by this time, some of you might be like, let's pick it all off. But you have to wait sometimes. Let the skin evolve, let it heal underneath. He wasn't working at this point, which made him very upset. They couldn't operate with his leg like this. 3 weeks. Compression. Full 40. In fact, it probably was a bit more, I would say. 5 weeks. Healed. Done. So I think the key is work together. If you're not working, I know the gentleman asked the question earlier, find out who's the person I need to know. Who do I need to have coffee with? Who needs to be at my table? Because 9 times out of 10, they don't know who you are. And there's such a turnover now of us as nurses. So complexity, I think, is very variable, how we view it, how we treat it. I would argue there's nothing complex as such. Everything is treatable and everything is healable within the confines of what we've talked about today. And then finally, the other end of complexity was a case I was involved in 2019. This was a child that was born in 2016 with trisomy 9. It was a congenital genetic condition that leads to developmental abnormalities, musculoskeletal problems, etc. I didn't actually meet the child until 2018, but she was born then. And part of this congenital problem is the valve in the heart, which meant that they had to go up through the groin, the vein, to repair that. The veins of a child this age are millimeters. So we talked about 6 millimeters for an adult young female. millimeters, so hair-like almost. When they were repairing the valve in the heart, they caused a fistula, which meant there was a hole leading from the artery to the vein. So you had the arterial blood flow going into the femoral vein in the groin. So you had this high pressure, high velocity. Now at the time, nobody had recognized that this problem had been caused this iatrogenic fistula. So nothing was done. She was casted for her musculoskeletal problems. As you can see, part of this condition, children are born severely underweight. It's hard for them to thrive. I'm not a pediatric nurse, but I learned a lot about it. By 2017, she had developed what some may consider as a lymphedema, but there's definitely edema there. She had staining. She had all the signs of end-stage venous disease. Still nothing was done. They thought it was a venous malformation. So there were no further investigations done. I got a call from my colleague and friend at Great Ormond Street, who had never managed a venous leg ulcer. What do? It's the week before Christmas. Well, you get on the bus and you go down to Great Ormond Street. And this is what we've talked about today, is bypassing red tape. Now, I was fortunate to have a relatively supportive director of nursing. So I could send her an email and say, I'm going to Great Ormond Street. She had already been referred to our vascular team, so I knew that was in the pipeline. But I wasn't going to wait for 10 meetings and a tick box to see the child. And that's what we need to be a little bit kind of diplomatic and negotiate with. There's a lot of red tape the way we work at the minute. Brought the Doppler with me, checked the signals, triphasic, started around compression. The evidence around compression for children in venous leg ulceration is almost non-existent. There's a few case studies from India, that's it. Lymphedema, there is, but there's nothing around what compression therapy to use. I started the child on Actico short stretch because that's what they use in lymphedema, to the knee and then to the groin. Unfortunately, things did not improve immediately. And when she came to our vascular team, it almost presented like a venous gangrene. I don't know if you're familiar with that or if any of you ever come across a venous gangrene, but the foot was very much like that. We carried on. The vascular consultant could feel the pulse. We carried on. So this was hugely traumatic for the child and the mother, who used to get the bus herself from the other end of London. The father worked abroad. There was another child in the house. There was a lot of emotional anxiety about this little girl, who by the time I was seeing her, she was 2. The child was non-verbal at that stage, and she recognized me by the uniform. I was not liked at all, which was hard for me to take, to be honest, spending 2 hours sweating, dressing a leg like that. And that is how long you would spend cleaning, debriding, bandaging a 2-year-old child that wriggles a lot and cries constantly. But we persisted. And I think the key part of this was either myself or my colleague did it. There was none of this, you're on annual leave and we'll get someone else to do it who we don't know. No, you can't mess about. You have to have somebody competent who knows the craft of compression. And I spoke to Trudy today about compression and it being a craft. It is an art, it's a skill, and we need to be able to develop it with our experience. It's not a half-day workshop. It's something you learn and you get better at and you can manipulate according to your experience. Otherwise, I wouldn't have been able to treat that child. I would have said, there's no evidence, it's controversial, I'm not doing it. She would have lost her leg and her foot. But that's where experience comes to play with teamwork. And then finally, by I suppose March 2019, which you think is a long time since her first original fistula formation, which they did eventually, after a venogram, figure out what happened. She began to thrive, she began to walk, she began to sing, play, etc. And we carried on. And she healed. And I think to me, this is, kind of the end of complexity for an adult nurse looking after a 2-year-old with a team of pediatrics, dermatologists and vascular. This is when great things can happen. It's not done in isolation at all. So I think if there is patients out there that you're seeing, they're not healing, there isn't an underlying really diagnosis, you can't get to the nitty gritty of it, ask somebody, ring me, email me. You know, it's having these conversations. If Rachel hadn't rang me from Great Ormond Street, what would have happened to that child? The leg was gone. And I always say to Rachel, because she was very senior, it took a lot for you to ring me and say, you know, let's do this. And it does take that kind of, positive contribution. So yeah, that to me is kind of the epitome of what I think MDT working is, when you can heal a child's leg like that and give them back their life. Thank you, everybody.